So what we're going to do is we're going to go through osteology, and then once we get done with osteology, we're going to skip over to chapter 5, and we're going to talk about the anatomy specific to the upper extremity. This next test is going to be over upper extremity and shoulder girdle, so it's going to be over chapters 5 and 6. So with osteology, we're picking up on page 55, and that's the most recent, this ugly black version of Merrill's. What is 16th edition? What we're going to talk about is skeletal divisions. I think we've got I thought we had a motion. Skeletal division, general bony features, bone development, classification of bones. There's classification of, here we go, classification of joints in here as well. We're not going to spend really any time on that, except for a couple of them. It's just not going to waste a whole lot of time. We've got a lot of stuff to cover between this week and next. So primarily, that's what we're going to talk about. I do want to warn you against, when you start studying for the test and you get home, you start looking at the information out of the next two chapters. There are a lot of projections in here, and what we're focusing on are just the ones that are most common. Okay, so if we don't cover it in here and we don't cover it in lab, don't waste any time on it. Okay, so sophomore year we're going to pick that up, and you'll cover those things with Amy in I forget what the name of the class is, but she covers it in the second year. So we'll get to that eventually. Don't clutter you. It's not a penguin at this point. Those things aren't a penguin, so don't spend any time on it. Yeah.
On the sure path, you were talking about our grades, but a lot of the upper extremity is a lot of just random.
Yeah. Unfortunately, on the sure path, I can't go into each one of those and ferret out the things I don't want you to have to study. So it's probably good to have some level of familiarization, but don't spend your study time working on those things, because it's just not going to do you any good for this upcoming test. So then, since we finally got overheads, overheads, old term, slides, then we'll talk about the purpose for your bones, bony framework, is primarily for protection. If you had no bones, essentially you'd be an earthworm, you'd be squashable, right? So it provides some sort of foundation for a rigid structure for protection of internal organs. So you really see that in the thoracic cavity, where you've got ribs all the way around, so you got a bony structure all the way around. Less so in the abdominal cavity. You've got some bony structure protecting your abdominal contents, but not the same as what you have in your thoracic cavity. So also the mechanical basis for movement, on a fundamental level, we're just levers, right? So the bones are attached to ligaments that attach to muscles, so that we can move much more easily. Protection for internal organs, we talked about support for the body, storage of calcium, phosphorus, any kind of minerals goes inside of the bones. So we tend to think of the bones as calcium, but there's much more than that. There's all kinds of minerals in there. And then production of red and white blood cells. And in children, red blood cells are produced, in everybody, red blood cells are produced in the red marrow. But in children, that red marrow is throughout the body. But as you grow and you become an adult, then your red blood cells are really produced in the flat bones, much more so than anywhere else. Your long bones, we're going to talk about what those are full of just fatty marrow. It's yellow marrow. So red marrow is throughout in children, and then as we age, they get, a lot of them become fatty marrow. So when we're talking about the skeletal divisions, we've got two different divisions. One is the axial skeleton, one's the appendicular skeleton, and that's color-coded on page 55. So in those two types of skeletons, what we've got are 206 bones, and that does really vary a little bit. Some people have 4 lumbar vertebrae, some people have 6. Some people have ribs on their 7th cervical vertebra. It's pretty rare, but that's what we refer to as cervical ribs. So they've got 13 pair of ribs. Some people have accessory small bones that we call sesamoid bones. We call them sesamoid bones because they look like sesame seeds. And kneecap is an example of what a sesamoid bone is. And we see those in different places within the body. You'll have a patient that it looks like they've got a specific type of fracture that we're going to talk about here in a bit. But it's not a fracture, it's an accessory sesamoid bone that is a normal deviation. So what a normal deviation, what that means, if you read that somewhere, is it's common enough that it's not an anomaly, so to speak. It's not a deformation. It's common, but it's not the norm, if that makes sense. So 206 is the normal. Anything beyond that is typically a normal deviation. So divided into two sections, again, axial skeleton is 80. We have 80 bones, and the appendicular skeleton is 126. So the axial skeleton is what's at midline, and then the appendicular skeleton, you know, your appendages, so your fingers, your hands, and so forth. So that would be your axial, exactly. So general bone features, what you have in most of your bones that aren't solid, most of your bones are not solid. Most of the time that you get to a bone that is solid is because it's been fractured, or you've got some sort of pathology that caused it to be more solid than what a normal bone would be. So compact bone would be the outer portion of the bone, as opposed to the inside would be a spongy bone. And that spongy bone we'll refer to in a couple of different ways, cancellous bone, or possibly, and not really possibly, but the framework inside of that is kind of, if you've ever seen an x-ray of a hand, you see these little squiggly lines inside of the fingers. And that's what we call trabecular markings. So trabecular bone, cancellous bone, all really mean the same thing. And then the outer portion, again, is compact bone. That's very dense. That's what you tend to think of when you look at a bone. You know, here we have an entire upper extremity from the top of the humerus all the way down to the tip of the fingers. And so you think of the bone, you think of that, right? But if you've ever seen a bone that's been cut, then the inside of that bone is a little bit more spongy. So the outer portion is very compact. That's what we refer to as cortical bone, or the cortex. You know, cortex is something as the outer portion of something. So that's cortical bone versus cancellous bone. We already talked about that, where the red and yellow marrow lives, so to speak, but the medullary cavity is the area in between the compact bones. So again, if you were to cut a bone, and everybody's seen this, you know, if you've got a dog, you've seen this. Even if you don't have a dog, you've seen this. So you go to the meat market, right, and you buy a bone for your dog, bless you. And a lot of times they'll have just one of these long tubular bones like this, and they'll have it cut, and the inside of that bone is hollow, and that's your medullary canal. So that's where the marrow is, and also the trabecular bone, and it can come out relatively easily. A dog, you know, has a tendency to lick that out. So that's your medullary canal. It's central cavity, and it's where typically your yellow marrow is, and again, your red marrow may be in the ends of the long bones, but they're certainly in the flat bones. If you know anybody who's ever done a bone marrow transplant, donated bone marrow to somebody who needs it, then in a lot of cases it'll go straight into the sternum. I gotta love you a lot for somebody to want to stand on my sternum and drill a hole in my sternum, which my heart is directly underneath that. It's probably not going to happen. If you come to me, ask for a bone marrow transplant, it was nice knowing you. So the periosteum and the endosteum is kind of like a covering, kind of like what we saw in the pleura. That's covering of the bone. Periosteum covers the outside of the bone, and the endosteum, just word association, in, only this is en, in is inside, right? Endosteum would be the lining on the inside of the bone. So it lines the marrow cavity. So ossification is just the development of bones. And we've got primary and secondary areas of of ossification, and it's going to surprise you a little bit which is which. So ossification begins in the second month of embryonic life, so it's very early in the fetal development. And so we've got intermembranous and inchondral, sorry. I was trying to make that a pathology, inchondromal. So flat bones, again, we're going to get into the different types of bones. Flat bones are just that, they're flat. Short bones, irregular bones, long bones created, the difference in those ossification. Flat bones are intramembranous, and the rest of them are through enchondral. It's just not wanting to come off the tongue very well. So those bones have two different centers. You got primary and secondary. So if you've ever seen an x-ray of a kid's bones, what you'll see is that they've got spaces in them, essentially. Those spaces are at the ends of the bone, and those are your epiphyseal plates. Those are your growth plates. And they're kind of cartilaginous, so when you take an x-ray of them, x-rays just go through that like they're not even there. So it looks like their bone is incomplete or even fractured. So you can see that. If I pass these around, and granted these are plastic mock-ups, but you can kind of sort of see around the proximal end of the humerus, especially kind of on this back side over here, you can kind of see where the growth plate heals up. So you can see those throughout the patient's body on the bone. If they're kids, they're going to be obvious. It's just going to look like the patient's got a fracture. If they're an adult, then you might see just a little bit of a line, but that's pretty much it. So it might surprise you as well that you'll get a 20-year-old person who still has open growth plates. So they're still growing. They're very small, but they're still growing. My dad is a prime example of that. He graduated high school. Obviously, I didn't know him, but he graduated high school. He was like 5'8", and he didn't stop growing until he was like 21, and he had 6 feet. So he was pretty short whenever he graduated high school, and his growth plates didn't heal up until he was 21 years old. So I didn't have that problem. I maxed out at about 10th grade. That's as tall as I'm ever going to get. So, but you have primary and you have secondary centers of ossification, and you're going to look at the bones and you're going to think, okay, this, the epiphyseal plates is where we get our length. That's got to be the primary center of ossification. That's where you grow, right? But it's not. Secondary. Primary is in the diaphysis, or the bulk of the bone, the body of the bone is your primary. Your secondary is where you get your height. Okay. So primary centers of ossifications are in the body of the bone itself. The secondary centers would be what we call our epiphyseal plates, or our growth plates. So classification of bones, we've got long bones, we have short bones. Back to long bones for just a second. Not all of your long bones are truly long. They're classified as long bones by their shape and not by their actual length. So you've got long bones, you've got short bones, you've got flat bones, which are mostly flat. You have irregular bones, and you've got sesamoid bones. We talked about sesamoid bones a minute ago. You've got those in various places. Where's the upper extremity? Okay, good. So if you look under the thumb, they're not separate, but if you look under the thumb, on the bottom side of the thumb, you'll see two little bumps. Can you see those? Yeah. Okay. Those are supposed to be representative of sesamoid bones. Okay, so you got sesamoid bones anywhere that you've got a joint that bends very acutely. Knee, very acute. But you've got them under your big toe, so you can kind of, if I can get the shadow on this just right, see that little bulge right there? Kind of get a little magnification. Those are supposed to be representative of sesamoid bones. So they can break. It usually happens in athletes that do a lot of high intensity, high impact type, athletic things like curling. You're probably never going to break that doing, what curling is, right? You know, slide the big rock and the shuffleboard is all it is. A shuffleboard on ice is what it is. Yeah, you're never going to break those bones in that. But like football and basketball, ever heard of turf toe? Okay, turf toe is kind of an extension of what you get with, you know, injury to that area. Okay, so specifically the fractured bone, you know, is potentially separate from turf toe, but turf toe could include a break of one of those bones. Very, very painful. Deion Sanders, you ever heard of him? He was out for an entire season for turf toe. So very, very painful. It's kind of hard to run if your toe hurts. All right, so sesamoid bones, back to long bones. Long bones are any kind of bone that's cylindrical in shape. So we've got, you know, a femur here. You're looking at a humerus and a radius and ulna that are coming around. Those, even though they're not completely cylindrical in shape, they are kind of cylindrical in shape. You know, they've got some features on them. You think of cylinders as just being like a coffee can with bottom cut out of it, or, you know, something like that, or toilet paper roll, you know, is cylindrical. Well, those are cylindrical in shape, plus they got some features on them as well. So that would be a long bone, that would be a long bone. But if you look at the fingers and the toes, they are also kind of cylindrical in shape, right? Even though, you know, especially on your pinky toe over there, that's pretty short, right? It's pretty small. It's still considered to be a long bone because it has that cylinder shape. So if you're looking at a bone that's, you know, got a cylinder shape,
So
it's a long bone, regardless of how long it actually is.
your phalanges are long bones?
Yep, yep. Every one of the individual portions of your fingers and toes would be long bones. And short bones, you know, even though, again, your phalanges are short, they're not considered short bones because they have a cylindrical shape. You get him all straightened out, by the time he gets back over there, fingers are going to be, you know, rheumatoid arthritis. So short bones would be things like your wrist bones. As this thing's coming around, look at the hand specifically. All of the hand bones are long bones. But if you look at those bones in between the forearm, which are long bones, and the hand, which are long bones, then those bones are what we refer to as short bones. So the bones of the wrist would be short bones. And flat bones, pretty obvious, sort of. You know, you get your sternum, it's, you know, very obvious. And your pelvic bones are fairly obvious, but also your skull bones. You look at the skull bones, they kind of curve, but they're still considered, most of them are still considered flat bones. There are some in there that are irregular bones, so we've covered everything except for irregular bones. What do you suppose irregular bones are?
Your vertebra.
Okay, your vertebra, but pretty much everything that doesn't fit into those other categories. So some of the bones of the skull, specifically on the inside of the skull, would be what we refer to as irregular bones, and our vertebra are also what we refer to as irregular bones. So we have long bones, cylinder shape. Short bones, probably a little more squared off. Flat bones, pretty flat. Sesamoid bones, something round, could be very small, look kind of like a sesame seed. If you've ever had a Big Mac, you know what a sesame seed looks like. And then irregular bones don't fit into any of that. So I just ran through all that, so I'm not gonna really spend a whole lot of time on those. And we will spend just a little bit of time on arthrology, but not a whole lot. So our joints are considered one of two things. They're either functional, so does it have a function? You know, can you see the function more specifically? All of them have a function, but can you see the function? Can you see your fingers move? And by functional, that's what we're talking about, is whether or not you can actually visualize the function. And the other would be structural. So when babies are born, you know, you got all the skull bones present, but they're not fused together, right? And that's by design so that whenever the baby passes through the birth canal, the head can compress a little bit. That just sounds miserable. That's something that I'm glad we don't remember, you know. So the head can compress a little bit, get smaller, go through the birth canal, and then, you know, it kind of expands back out. So what you've got are soft spots, fontanelles front and back, and we'll talk about that next semester. So you got the fontanelles, but those bones aren't fused. Later in life, they eventually fuse up and they become structural. Same thing with the pelvis. You've got bones in the pelvis that are fibrous, and they don't really move a whole lot. They might give a little bit, but they're not really functional bones as much as they are structural, okay? So functional bones, you can see the function. Structural bones just give you support of some sort. That's their primary function in life, is just to give you some sort of support. All right, so again, we're not going to go through every type of joint for right now. The ones that we're going to talk about are your slightly movable, and this is about all I'm going to say at this point. That will be amphiarthrosis, and then diarthrosis are your freely movable joints. And that's kind of where we're going to live for the next 4, 5, 6 weeks, right, in upper and lower extremity. Once we get into the pelvis and a little bit in the shoulder girdle, we're going to get into some amphiarthrosis, and then the synarthrosis are the things like your fused skull. You know, you can make a case for the teeth. I think they classify those as gumphrosis. I don't know. I'm not a dentist. So those are kind of like that. They just don't move at all unless something really happens and makes them move. Amphiarthrosis, slightly movable, and then diarthrosis. So we got fibrous joints, cartilaginous joints, synovial joints are the ones that are freely movable. And so, gomphosis, that's what I was looking for. So I'm going to make sure that we don't see, there's nothing else in here that I really need to stress. 6 types we're not going to go through. Ball and socket we're going to talk about. Pivot joints we're going to talk about. But we'll talk about those as we get to them. Hinge joint, you know, is pretty obvious. If it flexes and extends like the knee, then we've got a hinge joint. Pivot joints, obvious, you know, they kind of spin around. Most of the movement, we're going to talk about this later in the semester, but most of the movement, rotational movement in the C-spine comes from the articulation between the first and second cervical vertebra. So we'll describe, you know, how that works later in the semester. Ball and socket, we're going to talk about it quite a bit today. All right, so bony markings and features. Some of these things sound an awful lot alike, and really there's some bleed over between one and the other. So just kind of, you know, understand that there are going to be some things that sound identical. Everybody seen all of this? Okay. All right. So a projection or process is something that extends out from the bone. And some of them are going to have specific names. All right, so I'm going to start then with this thing right here. All right, so we've got 2 bones in our forearm. We've got a radius, and a radius is the bone that if you stick your arm straight out with your palm up, it's the bone that whenever you rotate your arm, it moves. This bone over here doesn't really move. So what really happens is your radius rotates. Radius rotates. All right, so when your hand is pronated, or I'm sorry, it's supinated. When your hand is supinated and your palm is up, then when you rotate, what happens is your radius rotates from one side to the other. But both of these bones have projections off of them. Can you kind of see that little pointy thing right there? That pointy thing right there? Those are projections. Those specific projections, we're going to call that a styloid process. It's on the radius, so that would be your radial styloid process. Okay? So this bone is your ulna, so that would be your ulnar styloid process. All right, so a process is a projection off of a bone. Process of projection. A depression is just a hollow or depressed area, and don't confuse depressions with things like sinuses. So next semester we're going to get into sinuses. And a sinus, a bony sinus, is a hollow area as well, but it's more cavernous than what your depression would be. You'll also see sulcus. Sulcus is also a type of depression. So a fracture, you're going to have patients eventually that are going to want to argue the difference between a fracture and a break. Anybody know what they are? Any difference?
It's that a fracture isn't all the way through, it's just a crack in the bone?
That's what your patient's going to argue with you. They're the same thing.
Oh.
They're the same thing. Fracture and a break are exactly the same thing. Okay, so your patient's you're going to get your X-ray, and then they go back to their room. This ER patient maybe, and then they come back for more X-rays, and or maybe this is after they put a cast on the patient. Whatever. Whenever we do a follow-up after they put a cast on the patient, it's what we refer to as a post-reduction image. So they set the bone, they send the patient back so that we can get a better look at the bone and see if everything is lined up as post-reduction. So, patient comes back and they'll tell you, well, the doc said it's fractured. He didn't say it was broken. Just nod, I mean, if you want to say the same thing, your patient's going to argue with you, and your job at that point is to not engage, just nod. You're not going to convince them. The doctor said it's fractured, didn't say it was broken. Okay, so you're not going to convince them. The doctor said. Well, the doctor just used one word instead of another. Don't argue with them, just go with it. So condyle is also kind of a projection a little bit, but it's a rounded portion at the end of the bone. Okay, so as this came around, you've got two condyles on the distal portion of your humerus. Okay, so it's articulation point. So you've got a condyle that articulates with the radius and one that articulates with the ulna. It's a cartilaginous covered into the bone. Okay, so a coracoid and a coronoid process, these really should be separated out a little bit, but a coracoid process is a beak-like process. So where we see a beak-like process, and I could have wheeled a whole skeleton down here. If my skeleton disappears, I'll lose the whole thing. So I didn't really want to wheel a skeleton down, so I got, just the extremities. But next week, I'll probably bring it down just for the day. I'm going to leave these down here because we might make it to the elbow today. I hope we do, but we're going to use these for this weekend next. But I'll wheel the skeleton down next week, and what you'll see is on the scapula, you got this thing that sticks out straight from the posterior portion of it's the anterior portion of the scapula, this posterior portion of the shoulder. This sticks straight out of the front. That's a beak-like process. Kind of looks a little like a crow's beak. It sticks out kind of like that. So that's a coracoid process, as opposed to a coronoid process. It's more crown-like. And you see a coronoid process in a lot of cases where you have some rotation going on. So crest is a ridge-like process. What's the common thing that we use for positioning of the abdomen? Iliac crest, right. So again, a ridge-like process. An epicondyle is above a condyle. Okay, so now we're going to shift over to our femur. So we've got a condyle articular process. So we've got a condyle that articulates with the top of the tibia at the tibial plateau. And then this area over here on the side that if you grab your knee, you got the big collection of bone on either side. Those are your epicondyles. So where we use the epicondyles is that on a good knee, and believe it or not, knee is really one of the harder exams to get right. It really is. And we'll talk about that, in a few weeks. But what we want to see is we want to see the epicondyles superimposed for a good lateral knee. What you're going to wind up with is a little bit of rotation or tilt in different ways, and hopefully just slight separation of those epicondyles. Slight separation, okay? You want them perfectly aligned. If you're on any of the Rad Tech Facebook pages, I know Facebook is kind of That's for old people. There's some really good pages on the in Facebook for students and whatnot. And probably most common X-ray I see students post that they're bragging about is lateral knee. If they finally get a perfect lateral knee, they're gonna post it because it's tough to get a good lateral knee. It's tough to get a perfect lateral knee. All right, so a facet is an articular surface, and it's a flat articular surface. So in between every vertebra, you've got facets, okay? And what a facet is just as it's described up there, it's a flat articular surface. So what you've got is a facet articulating with a facet to come together to create a facet joint. So you may know somebody who's had back injections, facet injections, and that's what they're doing is they're injecting cortisol, some sort of steroid in there to try to reduce inflammation and make them feel a little bit better. So a hamulus is a hook-like process, and the only place that I can think of that we really use that is, again, if you studied this real hard, you saw in the anterior portion of these, these plastic bones, you saw two things. One sticking out quite a ways, and that's actually supposed to be a bone, okay? So the one that's most proximal and lateral is a bone that we refer to as pisiform. So we'll talk about that here in a minute. But the one above that is not a bone, it's a projection off of the bone. Okay, so that would be a hamulus, okay? So it's a specific portion of the bone, specific process for projection. You got a head, expanded in, horn-like process. A line is just that, it's a linear elevation. A malleolus, sometimes referred to as a malleolus, is a club-shaped process. Now if you reach down, you feel your ankle, you can feel those two knots on either side of your ankle, okay? And those are malleoli, so malleoli, plural for malleolus. They are club-shaped, so where we see those, again, is in the distal portion of the tib fib, and you can see how this comes down and it just kind of expands out. You know what a shillelagh is? You see the leprechaun with a little cane, kind of looks like a shillelagh, right? So it comes down and expands out. Common area for fractures. So you got a common area, if patient twists her ankle, what you're going to learn is ankle fracture rarely includes ankle bone, which is here. Most of your ankle fractures are actually distal portions of the tib fib. Likewise, wrist fractures, I'd say 95% do not involve the wrist bones. They're going to be distal portion of the radius and the ulna. So common fracture of the lower extremity is to break off one or both of those malleoli. Okay, so if it, break the lateral malleolus off, then you got a lateral malleolar fracture, distal fibular fracture. If they break both of them, then it's going to be what they refer to as a bimalleolar fracture. So we'll talk about that again in a few weeks. All right, so protuberance, again, we got a projection. Spine is a sharp process, kind of like a line, but it's a sharp process. Styloid, we talked about that in the radius and ulna. That's a long pointed process. A trochanter is going to be very specific to the femur. So anytime that you see specific reference to something, this is a trochanter right here. It's a big mass of bone on the lateral side of the femur, proximal portion of the femur. So what we call that is the greater trochanter. Okay, so anytime you have a greater trochanter, you're naturally going to have a lesser trochanter. So that's your lesser trochanter. Okay, so anytime you see very specific things like anterior something, you're also going to have a posterior something. You have greater, you're going to have a lesser. Right. Superior, you're going to have a inferior. Right. Tubercle, the tubercle is going to be specific to the humerus, and it is to the humerus what the trochanter is to the femur. So you've got, you see that big knot of bone right there, right? So you've got a greater tubercle, and naturally, if you got a greater one, you've got a lesser tubercle, right? So these are going to be a little bit more specific for this next test. Whenever we do shoulders, that's what you're going to use to identify what position the patient was in. By position, I'm not talking about upright or supine, but rather degree of rotation. And some of the rotation in your upper extremity comes in the forearm, some comes in the shoulder. All right. So tubercle, tuberosity, large rounded elevated process. A fissure is a cleft or a deep groove. A foramen just means a hole. And you've got a lot of different foramen. You have nutrient foramen, and you see those in a skull. It's just a hole where blood vessels come through. A fissure or a cleft may be a place where blood vessels and nerves go through as well, but they're not a hole. So you see that little groove right there? That's what we refer to as the bicipital groove. Okay, so your blood vessels and nerves pass through that thing. We have a specific projection for that as well. Not real sure why. So if we have a pit or a fossa or a fovea, or that's just a hollow space, a groove, just like it sounds, shallow linear channel. A meatus is kind of like a foramen, but it's more tube-like. Like next semester when we get into skulls, we'll reference the ear hole a lot. And the ear hole, we're not just going to call it an ear hole, it's your external or possibly internal auditory, because it's your ear hole, meatus. Okay, so it's a meatus, it's more of a tube than what it is just a foramen, just a hole. Notch is pretty obvious. Sinus is more of a deeper, cavernous, hollow space. A sulcus is, you know, kind of like a shallow sinus. And then we get to fractures. So we've got four, you know, basic types of fractures. You've got closed fracture. So if you got a closed fracture, you're also going to have a open fracture. Okay, so these are the differences between fractures that are compound fractures versus not. Okay, so compound fracture means that the bone is sticking through the skin. That's an open fracture. All right, so a closed fracture would mean that it's not poking through the skin. We're going to have subsections or subcategories of those. Displaced versus non-displaced basically is the difference between how much manipulation is going to have to take place to get the portions of the bone back lined up, right? So again, in you know, fracture versus break, you know, the difference between a displaced versus non-displaced would be something like a crack bone. And adults understand that you don't crack your bone partway through. We're going to talk about that here in a minute. Kids, you can, but in adults, if you got a break, you're going to break it all the way through, most likely. You're going to have a place where the break goes, you know, from one place to another. And then that would be a non-displaced fracture. So the fracture line is obvious, it's evident, and it might not show up right away. So some people may go to the doctor with a fracture and they take an x-ray and they just don't see it. And then they go back 2 to 3 weeks and, you know, some of the swelling has changed and they can actually visualize a fracture. That's not because the original doctor was quack, it's because sometimes a fracture just doesn't show up right away. Okay, so if you have a non-displaced, you know, hairline fracture, what that means is it's broken, but it may be so subtle that any kind of deviation in the positioning might not show the fracture to be evident. Also, the swelling may be compressing it to a point you just can't see it. All right, so non-displaced fracture, the fracture fragments are still lined up, right? As opposed to non-displaced, somebody needs to set the bone, okay? So non-displaced fracture, you know, they just put a cast or a splint on it, send you home. Displaced fracture, patient may have to go to surgery. They may be able to set it in the ER, but they're probably going to have some degree of follow-up. So in those, we've got compression fracture. Compression fracture is where a bone collapses to some degree. And most of the time when we're talking about a compression fracture, we're talking about spinal fractures. It could be somewhere else, but we're talking about spinal fractures. So, you ever known anybody who over their lifespan, they were young and they had good posture, and later on they kind of slumped? Well, some of that could be because of loss of a muscle, right? But some of it could be because they have compression fracture, multiple compression fractures. So most common places for compression fractures will be in the T-spine, to a lesser degree the L-spine, even lesser degree the C-spine. My mom, when she was a younger woman, she had great posture. The older she got, the more evident she, just looking at her, it was like she had scoliosis. And she also had this little, bump on her back. So I never saw her x-rays, but I think before she, didn't have any kind of compression fractures. Later in life, she had some. She was osteoporotic, so she had some compression fractures. Compound fracture is the same thing as an open fracture. It's poking through the skin. Comminuted fracture is, it's technically, the definition of comminuted fracture is a fracture that's in 3 pieces or more. So somebody said, well, I shattered my ankle. I fell and I shattered my ankle. That's what they're talking about. Okay, so not all of your comminuted fractures are going to be that dramatic. Sometimes you'll have a comminuted fracture where it's just got a piece broken off of it. So you've got the fracture line, then you got a piece that snapped off of it. So if it's in 3 pieces or more, it's comminuted. Very common. We're going to skip over childhood fractures because I want to draw those. An impacted fracture is kind of like a compression fracture. But what you get with an impacted fracture, again, most of the time these are going to be osteoporotic patients. They trip and they fall down, and they might break a hip, but if they catch themselves, what might happen is they might break the proximal portion of their humerus. And the body of the humerus might slide just a little bit up inside of the head of the humerus, and that's an impacted fracture. Okay? Not to be confused again with compression fracture. The transverse fracture, just as it sounds, the bone broke straight across, as probably the most likely type to be non-displaced. Spiral fracture or oblique fractures are also sometimes referred to as bayonet fractures. What do you know about bayonets? It's a big ugly knife, right? So what you get then is with either one of these, a spiral or oblique or bayonet fracture, is you get a fracture that starts in one place and it goes down to another place. If it spirals around, then truly it's a spiral fracture. But what you're left with in those, if you don't have a butterfly broken off of it, and it's a comminuted fracture, is you have 2 very sharp portions of the bone. You got one on the proximal end and one on the distal end. And they can be dangerous, because what do you got going, up and down your humerus along with the bone? Arteries, nerves, those sort of things. So you got to be real careful with those just not to do any more damage to them. And a simple fracture is pretty much the same thing as transverse fracture. It doesn't have any complicating things like a comminuted fracture or sharp ends on it. So you may have many fractures or, a lot of different criteria in one type of fracture. You may have a comminuted fracture that's a spiral fracture. And it may be open fracture, so it's compound fracture, okay? So you got a lot of different things that can go into one type of fracture. Any questions?